Hello, and thank you for joining us here today. My name is Dr. Brian Haas, and I'm honored to be able to speak to you about an incredibly important topic that's often misunderstood about pain medications at the end of life. And in particular, we're going to talk about morphine and the fear that often surrounds it. Let's face it, this topic can be emotional, confusing, and most certainly frightening. But today we're going to break down the facts and talk about what morphine truly does and what it doesn't do. So I've got a little presentation here that we're going to go ahead and share with everybody today, and we're going to go ahead and move through some of these slides in order to help us come up with this process. So I feel it's important to understand pain medications, especially in hospice. And at the end of life, pain is very common, and it can be treated with a number of factors, including morphine, hydrocodone, fentanyl, as well as Dilaudid. But a lot of the times, patients' family members have concerns in regards to these medications. They are concerned about morphine maybe causing death, or hydrocodone is safer, or fentanyl is a very worrisome drug. And so I want to try and dispel some of these myths today. So why pain relief matters. At the end of life, pain is very common. It may be caused by disease or immobility or tissue damage. And patients who can't speak may even show signs of pain through their body language. They may grimace or moan or become very restless. And our goal as physicians, nurses, hospice care providers is to bring comfort. It's not to sedate. It's not to speed up death. It's simply comfort. So now let's talk a little bit about morphine. Morphine, when used correctly, it relaxes blood vessels. It can reduce the feeling of air hunger. It can relieve physical pain. And it's one of the most effective tools we have to make patients more comfortable. Now, of course, there's the challenge. Families often associate starting morphine with the moment of death. Now, this often brings us to this temporal relationship, and we have to look at timing versus the cause. That means morphine is often started very close to the time of death, but it does not cause death. So I want to repeat that. Morphine itself does not cause death. We give morphine because the patient is dying, not the other way around. The timing is close together because the symptoms become more severe near the end, and we respond to those symptoms with medications. So we have a lot of family fears, and often one of the hardest things to hear is when a family says, did we speed up the death by giving the patient morphine? And this is a heavy question, and it comes from a place of love, grief, and also fear. But as hospice professionals, we can help them to understand gently and truthfully that morphine is not the cause. The patient's body is already shutting down, and our role is to relieve that suffering that comes with that process. So this is where education really matters. A renowned hospice nurse and educator, Barbara Carnes, often said, education is 90% of end-of-life work. And this is what families need to hear, that what they're witnessing is normal. That may be sad, but it's not bad. And when we explain symptoms and treatments clearly, we ease the patient's pain, but we can also ease the family's fear. Now, families may ask, will morphine make them sleep more? Or will they still be aware as much? Can we give too much? And we can certainly start by saying, we give the smallest effective dose. And this is about easing pain, not sedation. They may rest more easily because they're no longer in distress. And we want to connect the medication to the patient's comfort, not to the timeline of death. Now, I want to spend a moment here talking about what are called morphine equivalents. So I want to clear something up. A narcotic is a narcotic, whether it's hydrocodone, whether it's morphine, whether it's Dilaudid or fentanyl. They're all working on the very same mu opioid receptors in the brain and the spinal cord. Now, what matters is not the name on the label. It's the dose. And that's why we use something called morphine milligram equivalents, or MME, to standardize opioid prescribing and compare potencies across different drugs. So let's do a couple examples because I think this is helpful. If we give someone a 5 milligram hydrocodone tablet 4 times a day, that is the equivalent of 20 morphine equivalents. Giving someone 1 milligram of Dilaudid or hydromorphone 4 times a day is also 20 morphine equivalents. So giving someone 20 milligrams of oral morphine per day divided in multiple doses again is 20 morphine equivalents. These are all clinically the same dose in terms of the analgesia. So when someone says, oh no, not morphine, or Dilaudid is stronger, you can say it's all about the dose and we match the strength to the patient's needs. Our job in this situation is to use these tools wisely. We don't want to avoid them. When used correctly, they bring comfort, dignity, and peace, which is exactly what we want for our patients in hospice or long-term care. So here's the truth. Morphine and other medications are not about giving up. They are about giving control. They're about giving relief and giving people the chance to be present, to rest, and to leave this life peacefully. These medications don't hasten death. They support dignity in dying. So let's replace fear with understanding. Let's replace doubt with knowledge. Let's help every patient and every family feel safe, supported, and comforted. Pain management is not the end. It's part of caring well, all the way to the end. Thank you. If you're a hospice nurse, thank you for what you do. Thank you for caring with courage, compassion, and clarity. We appreciate you. And if you're a family member that's struggling with this, I hope that you found some understanding in what analgesia is and what morphine equivalents are. Thank you.